Lorraine Johnson is CEO of LymeDisease.org, and she's principal investigator of the MyLymeData project. She has authored and co-authored many articles about Lyme disease, and she has been on federal panels, and she'll talk about some of that in her presentation. So, Lorraine, you're on.
Good afternoon. I want to thank you for that lovely introduction, Dorothy. I just wanted to add on a personal note that I became involved with Lyme disease over 15 years ago when I contracted Lyme disease and became what is known as a reluctant volunteer. And we're very happy today that we are hosting our second MyLymeData conference. I'm going to talk to you about where Lyme disease research is and about our big data project, MyLymeData, why we need it, what it is intended to accomplish, and why I think it can accelerate research in Lyme disease. Finally, I will share some preliminary results that we are beginning to pull together. But before I do that, let me tell you a little bit about LymeDisease.org so that you have a sense of who we are as an organization and why we launched MyLymeData. LymeDisease.org is one of the oldest Lyme patient groups in the nation. It was founded in 1989 as a small grassroots organization in Ukiah, California by Phyllis Mervine. And one of the things that distinguishes us from other Lyme groups is that we focus on directly reaching a large number of individual patients who we empower to act as a collective force to help create healthcare policy change. And we do this through patient empowerment and science-based advocacy, which is a pretty extraordinary combination. We start from the premise of patient empowerment, participation, and self-determination. And we hold patient-centeredness as our core value, working to empower patients. And we believe that there is strength in numbers and engage large numbers of individual patients on issues that are important to them by providing them with tools. Tools that educate, like our website, the Lyme Times, and our symptom checklist. Tools that give voice to patients, like our large-scale surveys, which have been published in medical journals, or Voter Voice, which gives patients political power in the legislative arena. And then finally, MyLymeData, which allows patients to pool their healthcare data to help find a cure. So we place a lot of emphasis on providing trustworthy content for patients and tools that patients need to improve their diagnosis, find a doctor, or figure out the best treatment options. And we've been publishing the Lyme Times for almost 30 years. So our library of archives of articles by physicians, researchers, and patients is one of the most extensive in the world at this point. Patients depend on us to tell them what's what, especially when news is breaking or its impact is uncertain. And Dorothy Leland, who heads our communications, likes to say that we are the Huffington Post of Lyme disease, and thanks to her, we are. Our website is one of the most trusted sources of information by patients. Today, our website reaches over 4 million unique visitors annually. Our symptom checklist tool allows patients to answer a series of questions about exposure, tick bite, rash, and symptoms that are suggestive of Lyme disease. We then provide information for the patient regarding the rate of the rash, for example. Once a patient has completed the questionnaire, there's an option for them to print out the PDF to go over with their healthcare provider. So this PDF serves not only to educate patients, but also their treating physicians, and it describes the two standards of care and the importance of providing patients with treatment options. We believe that this tool helps patients obtain an earlier diagnosis of disease. Over 2 million people have used our symptom checker. Another thing that we do to help drive health policy is we very quickly deploy large numbers of patients in support of or opposed to different legislative or healthcare policy matters. Our ability to rally a large number of patients to create policy change amplifies the patient's voice and gives patients an effective means of creating change. For example, we brought in over 10,000 in support of the HHS Lyme Working Group and 10,000 in support of removing Dr. Gary Wormser from the panel. And we did this within days, not weeks. But in addition to these types of efforts, you have to have data to make change. Like Deming says, in God we trust, all others must bring data. But this is a catch-22 for Lyme because the research just hasn't been done. And the fact is that patients need more than hope. They need data. About 10 years ago, we decided to help patients step in to create patient-generated data and to publish our findings in medical journals. These surveys collected data from generally over 5,000 people. So this is really big data survey research. And through these large-scale surveys, we developed a deep experience base for what questions worked with patients, what the expected floors and ceilings of a question might be, and how to determine when questions were not working. We use government-developed questions to the extent that they are available, and otherwise we use our experience with the disease, expert panels, and we beta test our questions on patients. So we worked with academic researchers at Stanford and Carnegie Mellon, along with biostatisticians, when we put together these two publications that you see on the slide. And if you're looking for published statistics on things like co-infection prevalence among those with chronic Lyme, disability, years to diagnosis, symptom severity, healthcare utilization, cost of illness, and so forth, I encourage you to take a look at these two publications. We really packed a lot of data into them. We also work with others to bring the credibility to the community by serving on government panels and participating in convenings or presenting before these groups, including the White House, the Institute of Medicine, the NIH, the Cochrane Collaboration, and my personal favorite, the U.S. Patient-Centered Outcomes Research Institute, or PCORI, as it's called. And I was fortunate enough to serve on both the executive committee and the steering committee of PCORNet, which is at the forefront of patient-centered medicine and big data research. So PCORI was founded under the Affordable Care Act, and it funded 18 patient-powered registries. And actually, MyLymeData was essentially born there. And I'll talk about that in a few minutes. But this is the sort of things that we need to be doing to make change happen. We also have worked side by side with other organizations promoting the HHS Tick-borne disease working group and its subcommittees. I mentioned that we use voter voice to help pass the legislation and remove Dr. Wormser from the panel. In addition, 3 members of our board are serving on subcommittees of the working group. Finally, just to close the loop, when Lyme organizations participate in these activities, they need to tell the world and generate press coverage that empowers patients further. So now that you have some background on LymeDisease.org and understand what our focus is, I want to shift the attention back to MyLymeData, which is what we are here to talk about today. MyLymeData takes the focus of empowering large numbers of patients and amplifying their voices to the next level. It allows patients to pool large amounts of data to help push the Lyme research agenda forward. So this is essentially about the democratization of science. And here's why we need to do this. This chart, taken from a study by Goswami, looks at the number of clinical trials being conducted in infectious diseases. So these are just infectious diseases that he's looking at. And what it shows is how large the research gap is between Lyme and other infectious diseases. So while diseases like HIV/AIDS, hepatitis C, and tuberculosis have a relatively robust amount of research being conducted, Lyme has very little. And the last human chronic Lyme treatment trial in the U.S. was funded over 15 years ago by the NIH. We need to change that. And remarkably, today we have the technological tools to change the way that research is conducted. So this is a quote from Harlan Krumholtz, who's at Yale, and he sits on the board of governors at PCORI, who, as I mentioned, is one of the largest government sponsors of big data research. And he says, in the next era of research, can we empower people to take action and not wait on academic centers? And then says, goodness, this is a new research paradigm. People with power, with their data, tech-enabled, and eager for partnership. And you can see that Stacy takes it a bit further, saying patients should collect and collate their data and partner with researchers rather than waiting years for bureaucracy and egos to get out of the way. I couldn't agree more. And that is why we decided to launch MyLymeData a few years back. And as luck would have it, I was sitting on the executive committee of PCORI and had this enormous opportunity to learn from the best and the brightest how to put together a patient registry and research platform. So we launched MyLymeData in the fall of 2015 as part of the patient-centered research movement. And that movement seeks to transform traditional research, which is done in a hierarchy of academic centers, and it's conducted on passive patients. So the move is to go into a partnership model between patients and researchers. And MyLymeData is a patient-centered big data research project. It was conceived by patients, it's run by patients, and it will address the issues that Lyme disease patients care about. We expect MyLymeData to gather more data about Lyme disease than any research study has done before. We have enrolled over 10,000 patients and collected over 2 million data points, which puts us in the top 5% of patient registries in the nation. So let me just put this in context for a minute. The largest NIH-funded clinical treatment trial for Lyme disease enrolled just 129 people. Recruitment alone took them more than 3 years, and they screened out 93% of the patients who applied. But here's the saddest part. 129 people in a trial is nothing. It's a trial destined to fail because the fact of the matter is that some people respond to treatment and others don't. And when you only have 129 people in a trial, you can't figure out which groups respond and which groups don't respond to treatment. So to do subgroup analysis like this, you need big data. So that is why we believe MyLymeData Patient Registry is a game changer in terms of research. It's more than simply a patient registry conducting an observational study, although that's actually very important. It's also a research platform that will facilitate research in generating hypotheses, recruiting patients, and providing long-term follow-up after a trial is completed. And it can also help to evaluate the quality of clinical care by tracking patients over time, seeing what treatments they're taking and how they're responding to those treatments. And the data from the registry can be used to help drive healthcare policy decisions. So this will be part of a big collaborative effort that it's a big research engine is what we're ultimately talking about. So research engines accelerate the research process dramatically. They have a lot of moving parts and they require a lot of collaboration. And here's what the process looks like. You launch a patient registry, you connect with a biospecimen repository, you use the data to conduct natural history studies, to help identify clinical endpoints, to help shape clinical trial hypotheses, to help recruit patients for clinical trials, to lend the patient weight in the FDA approval process, and to help with any post-study follow-up. So you might remember I said that MyLymeData was initially part of PCORI's big data government project. And you might wonder, well, why did you ever leave that position? It was actually a pretty sweet spot to find Lyme disease in the center of a patient-centered project. But unfortunately, we had to withdraw from that project shortly before launch to ensure that patients' data would be used for the benefit of patients. Lyme patients justifiably have heightened concerns about who is using their data and what it is being used for. So we vet researchers and we vet the use and reuse of data. We also limit data access to protect privacy and re-identification risks. And we call this patient-centered open data. So MyLymeData is extraordinarily patient-centered. What this slide shows is a spectrum of types of patient engagement that you can have in research. You know, and at the left end is consultation. That's kind of like, you know, maybe we'll be given an opportunity to comment on the IDSA guidelines. That would be consultation. They can listen to it or not. You know, involvement, which is like the HHS working group where you actually have a seat at the table. Collaboration, where you're working in partnership. And then also patient-directed research, like our Access to Care survey and our Quality of Life survey. So this is a place where research is being conducted is very patient-centered. So let me talk a minute about the data we're beginning to pull out and the types of analytical approaches that can be taken with this large group of data. And this slide shows different types of data analytics that can be useful with large data sets. We're just beginning to start working with phase 1 data now. We're pulling out descriptive analytics and looking for patterns that might emerge explaining why some patients remain sick while others get well. And we're also working with other researchers on predictive analytics. So one team of researchers that we are very fortunate to be working with are big data researchers at UCLA and Claremont McKenna. Deanna Needle and Blake Hunter. And they were recently awarded an $800,000 three-year grant from the National Science Foundation to explore predictive analytic techniques using data collected by the MyLymeData patient registry. So this is great news for both the researchers and for MyLymeData. Let me turn now to some of the preliminary things that we're beginning to pull out from the first year of data. And I'm going to give some examples from geographic distribution, subgroup analysis, and what patients reported their worst symptoms and the associated medications. So we're pulling this information together because we're in the process of preparing an annual report for MyLymeData. So one thing to keep in mind is that most of the patients in MyLymeData have either late-stage untreated Lyme disease or chronic Lyme, that is, treated Lyme disease that remains symptomatic for at least 6 months after treatment. So this is a very different population from people who are used in acute studies. I mean, people who are used in acute studies have no need to join a community, right? You catch a cold, you get better, you don't join a community about it. But if you have lingering or persisting symptoms, you're more likely to join a community. So 3 take-home points. 70% of the people in the registry report that they were not diagnosed until late stage when treatment is harder. Clearly, shortening the time to diagnosis should be a goal for Lyme disease. And 72% report that they were initially misdiagnosed, which I think is probably not a surprising figure for most of those in this room. And a whopping 60% report that they have co-infections. And so you have to contrast that with what we hear about the co-infection rate in acute infection with Lyme disease. They'll say, well, it's actually quite rare. Well, maybe it is quite rare in acute Lyme disease, but in patients with chronic Lyme disease, it's the norm. It's what you would expect to see. So this group of patients may respond differently to treatment and require novel treatment approaches. And to my knowledge, there has not been a study of the optimal treatment for untreated late-stage Lyme disease, but we clearly need this. So one of the projects that we wanted to do right off was to take a look at geographic distribution of the people who were in MyLymeData, so we put that together. And then we took a look at the geographic distribution of the CDC, and then we thought, well, why not? Let's take a look at the canine cases, which are compiled by IDEXX and CAPC. And then ILADS was kind enough to share with us their physician referral requests. And so if you look at the top left-hand corner, those are the CDC cases, and that's in green. And then if you look at the top right-hand corner, those are the canine cases in red. And then MyLymeData is the turquoise down in the left corner, and the ILADS physician referrals are the darker blue in the bottom right-hand corner. And one of the things that should pop out at you about looking at these maps is that if you look at the CDC green map, you'll see there are 4 states that have no Lyme disease in them. And yet all of the other maps reflect Lyme disease in those states. So that starts to suggest to you that perhaps what the CDC is capturing in its surveillance definitions does not accurately reflect the geography of the disease. And, you know, if you're looking at the issue of risk exposure, now what is my risk of getting Lyme if I hike here or hike there, your best way of doing that is really going to be to look at the canine cases, because the canine map has the largest number of cases by far. They screen the dogs, so it's basically 1 million, dogs are included in the canine cases, compared to 38,000 CDC cases, about 20,000 ILADS physician referrals, and in this sample, about 6,000 MyLymeData cases. So the other thing I would say is note how similar the distribution is on the canine, the ILADS physician referrals, and the MyLymeData maps. And this also suggests that the CDC geographic distribution is out of sync. And when I looked at this data, it led me to think that the cases in the South and the West were either not being identified and reported, or that they were not being counted by the CDC. And either way, it's the patients in these states who are left undiagnosed and untreated. And so I pulled out separately the cases in the South and the West to see if this was the case. And what I did was I did a comparison of the number of CDC cases reported with the number of cases in MyLymeData. And there were 24 states where MyLymeData had more cases reported than the CDC. And that's kind of surprising because our sample size was so much smaller than the CDC's. You know, we had 6,000 people in this sample, and the CDC had 30,000. You would expect them to always have more cases than we did. And then we pulled the canine cases, which of course are, you know, in the purple here, they're huge because, you know, there's a ton of canine cases that are tracked, and looked at the physician referral cases, which were in the green box with a stethoscope there. And, you know, the bottom line was that everybody was reporting more Lyme disease in the South and the West than the CDC was. The CDC's that little tiny blue box in the right-hand lower corner with 513 cases. So again, that suggests that there's something out of sync with the CDC geographic distribution for the disease. And that's how you start to tease this sort of stuff out. You start looking at different data sources and seeing what looks right, what doesn't look right, what's out of sync. And then the next thing that we wanted to look at was we wanted to look at this question of, it's called treatment heterogeneity or patient heterogeneity. It's when people are different. There's a lot of variation within a group. It's called heterogeneity. This is what happens, you know, essentially when your average patient is not average. This happens in diseases when treatment response varies or when people have different co-infections or length to diagnosis is different. So sometimes the average is not what you want. A popular mathematician, McHale, likes to point out that the average human has one testicle and one breast. True enough, but how useful is it to know that? And the important factor here is the subgroup. Are we talking about males or females? And this is true in Lyme disease also. What we need to start doing is identifying subgroups of patients. For example, patients who respond to treatment and patients who don't. So when we designed the MyLymeData survey, we put in a question that was intended to allow this really large range of granularity of your response so that you could really differentiate different groups. So the survey included a simple question for our patients. It was, how much have you improved since treatment? I'm better, I'm unchanged, or I'm worse. And then if you said you were better, it said, well, how much better? Are you hardly better at all, or a great deal better? And the same thing on worse. Hardly worse at all, or a very great deal worse. And you can see the distribution of responses here that we were asking about. And I want to acknowledge Myra Shapiro, the biostatistician who worked with me on this project and helped provide some of this data. And what we found was interesting. So the average treatment effect, which is that brown little diamond up at the top, was 1.7. Not really much of a treatment effect at all. I mean, why bother? A treatment effect that small, you know, it's going to have some side effects. Probably not worth it. And this is basically what the NIH trials concluded. But most patients do not have this treatment effect. Instead, they respond differently. And when you look at the group of patients that we called high responders, the average treatment effect was 5.3. You know, well, 5.3 on a 7-point scale, that's actually quite a bit of improvement. So what percentage of the patients in the study were high responders? And it turned out that approximately 34% fell in the high responder group. And these were people who reported being moderately to a very great deal better. So it's important to note that this is really exploratory research in the sense that we're just trying to see if this type of a scale provides useful information and whether it can be helpful in the conduct of research. So the next question, if you've got 34% of people are high responders, is that good or is that bad? Should it be more than 50%, 60%? Would you expect it to be 70%? And what we did was we looked for the success rates in other diseases. So Dr. Alan Roses, who was the chief of Glaxo at the time he made this statement, says that the vast majority of drugs, in fact more than 90%, only work in 30 or 50% of the people. And then he goes on, he says, I wouldn't say that most drugs don't work. Drugs out there on the market work, but they don't work in everybody. The idea is to identify responders, people who benefit from the drug. And he was actually going after the role of genetics in drug treatment response. So this is, you know, as I said before, it's observational analysis, it's preliminary, it can't prove cause and effect. But understanding that subgroups of patients may respond differently to treatment in Lyme disease will move research forward. And, they're doing this in other diseases where they've got, like tuberculosis, it's, fast responders, slow responders, partial responders, non-responders. And, the point here is that not all Lyme patients are alike, and looking at subgroups may be extremely important, and you can only do that if you have enough data. You have to have a lot of patients enrolled in a study to do this type of analysis. So one last topic that I want to address before I conclude is patient symptoms and medications associated with those symptoms. So we asked patients what were their 3 worst Lyme disease symptoms, and here's what they said. And most of these are no surprise people with Lyme disease. The worst rated symptoms were fatigue, followed by joint pain, muscle aches, cognitive impairment, and then came along neuropathy, sleep impairment, psychiatric, and GI distress. I might address some of these symptoms that weren't antibiotics. So, we asked patients, what other medications are you taking? So I apologize, I know this slide is a bit complicated, but if you look up in the top left, you'll see the blue bars, and those are what we call the 3 worst pain symptoms, which were joint pain, muscle aches, and neuropathy, and headache. And then if you look at the table over on the right-hand side, what I did was I pulled out U.S. government statistics where they existed for use of varying medications that we had asked the MyLymeData participants about. And if you'll focus just in on the prescription pain relievers, you see that 26% of those in MyLymeData reported taking prescription pain relievers. I don't know, how that hits you, but I was just really surprised it was that high. And I think it's pretty important to know that it's that high. And then if you look at the normal U.S. range, it was between 9 and 16%. So really, quite a spike in prescription pain relievers among patients with MyLymeData. And then we also took a look at some of the other symptoms. So fatigue, sleep impairment, psychiatric, and the medications that might be associated with those. And sure enough, you're seeing the same pattern. There were more patients with fatigue taking thyroid medications, a lot more use of sleep medications, a lot more use of antidepressants. I mean, in fact, some of these are like 4 times as much as the national average. So it's showing you a picture that even if, 50% of the population in MyLymeData are not taking antibiotics, but a lot of people are taking different prescription medications of one type or another. And if you don't address the underlying cause for the fatigue or for the sleep impairment, these people are going to be on those medications probably for life. And all of those medications have side effects. So when you're talking about cost of illness or burden of illness, a lot of times we think, oh, well, the insurers are, they're not going to like paying for antibiotics. But the real question is, do they like paying for all of these substitute medications, and what are the health risks associated with those? So I think it's an important area to look at. And I'm going to end by just noting that we also asked about medical marijuana, which can be used for pain relief, anxiety, nausea, or sleep. It was the 6th most popular alternative medication used by our sample, and 60% reported that it was moderately or very effective. So this again points to the potential use of medical marijuana to relieve some of the more common symptoms of Lyme disease. So let me stop where I began. We expect MyLymeData to be one of the largest studies in Lyme disease ever conducted. If you're not part of MyLymeData, please enroll today. If you're a researcher, a biostatistician, a potential partner, or someone who just wants to help with this project, please contact us. We believe this project could change the future of research in Lyme disease, and I want to thank you for your time.